Hi, everybody. I am Alice Gallo, an intensivist at Mayo Clinic, and it's my absolute pleasure to host today's CHEST webinar supported by HHS CDC Grant Cooperative Agreement. I have three fantastic guests with me today, and I was hoping they could introduce themselves. So, Katie, I'm going to start with you. Welcome, friend.
Hi, thank you. I'm Katie Pendleton. I'm an adult pulmonary and critical care doctor at the University of Minnesota, and I'm really excited to be here today.
Thank you for being here. Angel?
Thanks, Alice. Hi, everybody. My name is Angel Cos. I am pulmonary and critical care at the Cleveland Clinic. Happy to be here as well.
Thank you. Chris?
Hi, yes, thank you for having me. I'm Chris Carroll. I'm a pediatric intensivist at the University of Florida.
Today's webinar is going to be a little different than our normal webinars where we discuss specific topics or papers or something or things like that. We're going to talk about cases today, and we're going to hear from our three guests how they would approach this sepsis cases differently, similarly, and what they take into consideration when they take care of their patients with sepsis. So we're going to start with Katie. Friend, if you see a patient admitted to your ICU 5 days ago with septic shock from pulmonary cause, sputum and blood cultures were positive for strep pneumo. But today, day 6 of the ICU admission, they have a fever of 40 Celsius. They are off pressors for the past 36 hours, and they have been extubated for 18 hours. They stayed in your ICU due to lack of floor beds. Do you think that they are becoming septic again? Walk me through your thought process. How would you approach this fever? Tell our listeners everything you would be thinking through.
All right. First of all, I just have to say how much I love this case because I feel like this is an adequate representation of something that happens to most of us, like near daily in the ICU. So in a word, sepsis, not sepsis, I would say maybe sepsis, but certainly I think starting out from the information I have, my suspicion is a little bit lower. I think starting with this case, just thinking about focusing on the patient in front of you and the clinical trajectory, right? So this is somebody who's been weaned off oppressors for a day and a half, is maintaining their own hemodynamics, successfully extubated, getting ready to clear that 24-hour mark post-extubation. And really, if not for lack of bed availability, would have left the ICU, and this fever would have been somebody else's problem. But here we are, so the things that I would think about for this patient would be, first, I'm presuming based on their presentation that they're probably still on antibiotics from their initial bacteremia and pneumonia. And just, double checking that we haven't had a medication or a medication lapse where they've ended up with a 3 or 4 day course of antibiotics as opposed to a longer one, which they may benefit from. Assuming though that you started with right drug for the right bug and this person is improving, I would really be thinking about other causes of fever for this person before I'm pulling the trigger on things like antibiotics. I'd be wondering about drug fever, for instance. That can certainly happen with antibiotics. If this person was on Precedex recently, that's a common culprit. Work up for things like DVT, which can be cause of occult fever in ICU patients and somebody who otherwise doesn't look toxic. And in my real life clinical experience, I would this is somebody that I would probably get surveillance cultures on if they haven't been cultured in the last 24 hours. But unless they showed signs of clinical deterioration, I would probably not be changing antibiotics at this point.
Oh, I love it. Treat the person, not the numbers. I love it. Angel, do you have anything else to add or any different pathways that you would take on your thought process for this patient?
Absolutely. I think there is, when we have this case, which as Katie said, resembles in the day-to-day practice, that patient is getting better, all of a sudden now there's a fever, and now what do we do with it? In this case, one thing that I would particularly pay attention is if there is a parapneumonic effusion, because if you have a patient with a pneumonia that initially got better, and now there is a new fever, there could be a collection of infected fluid or inflammatory fluid that might be a new source that needs to be controlled. So I agree with everything Katie said. The only thing that I would probably add was maybe either an ultrasound or a CAT scan, depending if the images are not feasible or not good quality, to see if there is an additional pocket of fluid that needs to be drained, because that could explain why fevers are recurring a few days later.
Chris, is there any particular features or signs that you look differently than what us adult intensivists look for when you're treating your kids?
Yeah, it's amazing how similar their responses, Katie and Angel's responses, were to what I would have said as well. You know, in pediatric, secondary or prolonged fevers are not uncommon. Like Katie, I'd want to know more about this person's course. Sepsis in children is defined based on a 2005 statement. So we're due for a redo of our sepsis definitions. And the criteria for sepsis in children are 2 or more age-based SIRS criteria. So that's tachycardia or bradycardia, high respiratory rate, fever, or leukocytosis or leukopenia. So you need 2 or more of those. And then you also need a suspected or proven infection. And then cardiovascular dysfunction, ARDS, or 2 or more non-cardiovascular organ system dysfunction. So this patient doesn't technically meet the criteria of sepsis at this time, but I completely agree with Angel that you need to look for source control issues, and looking for an empyema on this patient would be important. Also, this is a patient with pneumococcus. Antibiotic resistance patterns differ in pediatrics. That's something that I think you guys pay attention to in adults too. Since this is audio only, no one can see everyone's laughing. But at least in peds, it's about 30% where I live is resistant. So something to consider as well. But like Angel, I would be looking for an empyema on this patient. I would consider changing antibiotics or broadening antibiotics, especially since I don't want them to come back to my ICU.
And I would just piggyback quickly onto something I think both of you said. Somebody who's getting ready to leave the ICU but was really sick, also paying attention to lines and Foley's, and if we've done our due diligence in terms of delining people, especially with respect to source control.
Absolutely.
Read my mind. That was going to be my follow-up question. I love it. And anything else that you would be thinking? We talked about lines. We talked about drug-related fever, making sure that we chose the right antibiotics for this strep pneumo, because we probably already had speciation for the pediatric population, making sure that is age-appropriate SIRS criteria is being met, which sounds like in this case it was not, because it was just fever, and thinking about delayed complications from something that sounded like was a simple pneumonia with bacteremia, such as now an empyema or an abscess in the lung or somewhere else. Excellent. Anything else? Oh, I love this. We have a consensus. This is very unusual in critical care. I love this. Thank you so much for all of you for joining me this afternoon for this CHEST podcast, supported by AJGS CDC Grant Cooperative Agreement. Please go to the CHEST Sepsis Topic Collection page, and you can find the ways to reach out to us there, and also leave comments and questions for us there.